This is 4071. We're still in lesson 1 in imaging studies of the brain. Today our topic is going to be on perfusion scanning. CT perfusion studies are specialty studies that are performed to provide information of blood circulation in the brain. Perfusion studies are obtained by monitoring the passage of iodinated contrast through cerebral vasculature. CT perfusion software that interfaces with helical scanners can meet the clinical needs for evaluation of acute and subacute stroke. Such applications produce a quantitative measure of regional hemodynamics by demonstrating blood flow in each pixel of the cerebral parenchyma that's imaged. This technique is based on the central volume principle, which states that cerebral blood volume can be calculated as the product of total cerebral blood flow and the time needed for the cerebral blood passage. The goal in performing perfusion studies for patients with acute stroke is to distinguish infarct tissue from the penumbra. So we've got a lot of definitions to go over, but first let's talk about the actual protocol for the CT brain head perfusion. First thing that's done is a non-contrast CT head. The next thing is a CTA of the brain is performed. The third thing is the perfusion portion of the study is performed, where after the CTA brain is complete, 25 to 50 milliliters of contrast is injected at about 4 to 5 milliliters per second, and then multiple cine coverage of the circle of Willis is obtained for up to 1 minute. The next step is to place ROIs, or region of interest, over arteries and veins on the perfusion map that's created. And then the computer calculates the CBF, CBV, and the MTT. We'll talk about those in just a second. Mathematical technique utilized for generation of perfusion maps is called deconvolution. All right, so let's define cerebral perfusion first. It refers to the level of blood flow throughout the brain tissue. CT perfusion evaluates the cerebral perfusion by monitoring the initial passing of iodinated contrast media through the vasculature of the brain. The factors that are used to describe cerebral perfusion are the CBV, which is the cerebral blood volume. It's the quantity of blood in milliliters contained within a 100-gram volume of brain tissue. The normal range for it is 4 to 5 milliliters per 100 grams. The CBF is the cerebral blood flow. It's the quantity of blood in milliliters that moves through 100 grams of brain tissue each minute. So the normal range for gray matter is 50 to 60 milliliters per 100 grams per minute. The MTT is the mean transit time, and it's the average transit time in seconds for blood to pass through a given region of brain tissue. MTT varies according to the distance traveled between arterial inflow and venous outflow for a particular area. The formula to calculate the cerebral blood flow, which is what we want, the CBF, you divide the cerebral blood volume, the CBV, by the mean transit time, and that will give you the CBF. As I said earlier, the primary indication for CT studies or CT perfusion studies is the evaluation of acute stroke. And the primary goal of the CTP is to identify and differentiate the infarct core from the penumbra. So let's define what the infarct core and the penumbra are. The infarct core is the tissue that's beyond repair by thrombolytic therapy. Remember, thrombolytic is the clot busting therapy. The penumbra is the ischemic yet still viable tissue immediately surrounding the infarct core. It's the good tissue that we can still save. In order for the brain tissue to be classified as penumbra, that region of ischemic brain parenchyma has to have a CVV that is still greater than 2.5 milliliters per 100 grams. In order for the brain to be classified as the infarct core, or the dead area, the brain parenchyma must have a CVV of less than 2.5 milliliters per 100 grams, which basically means there's little to no blood flow to that tissue. So to summarize, when performing a CTP, initially a non-contrast CT head is performed. Afterwards, a CTA of the brain and carotid arteries is performed with the administration of contrast. And then during the perfusion phase, a bolus administration of 50 milliliters of contrast is injected at a rate of 4 to 7 milliliters per second. Cine acquisition, which means rapid sequential acquisition in the same location over a period of 50 to 60 seconds, is obtained. This allows for complete tracking of the first pass of contrast agent through the intracranial vasculature. It's important to keep track of the patient dose during these exams and let it be kept to a minimum during this extended period of scanning. Then we place region of interest measurements over well-opacified arteries and an area of venous outflow. An example of that would be the anterior cerebral artery and the superior sagittal sinus. In the computer software, we utilize the region of interest information to generate a color-coded CBF, CVV, and MTT maps. As you can see, these are very complicated exams. Both textbooks explain CTP very well. DeMaio is a little more concise, but I encourage you to read both texts and study the images and what they mean in the Romans text. Our images are better than in DeMaio. Some of the key concepts listed in Romans are: perfusion studies are obtained by monitoring the passage of alternating contrast through cerebral vasculature. And CT perfusion is most frequently ordered in the evaluation of acute stroke. It's also ordered for vasospasm or tumor grading. There are a couple of other uses for CTP explained in Romans briefly. They're CT perfusion to determine cerebrovascular reserve and CT perfusion in conjunction with temporary balloon occlusion. I encourage you to read over those, but I won't test you on them. I don't know how much of that you'll see on the registry as well. All right, so that was our CT head perfusion studies. Now we're going to talk a little bit about types of strokes. Since we studied the CT perfusion, I just wanted to add this topic in to kind of help you know what you're looking for and to help you understand the strokes, the CT perfusion, the reason we do them a little better. These are just definitions, and we won't go into much detail on the slides because we're going to cover all this in greater detail in pharmacology class. So strokes fall into two different categories. They can be, number one, ischemic stroke, which is where a clot blocks blood flow through an artery, or they can be hemorrhagic stroke, which is also known as a blowout bleed, and this is a rupture of the vessel with bleeding into the brain. Now, there are two types of ischemic strokes. The first type is embolic, and this is when a clot forms within the body and it travels to the brain. It gets stuck in the small vessels, occluding the blood flow. And then the second type is thrombotic, and this is when a clot forms and blocks blood flow through the artery as a result of atherosclerotic deposits within the vessel. Thrombotic ischemic strokes most commonly occur in larger brain vessels, and atherosclerosis is the most common cause. So when thrombotic strokes occur within small vessels in the brain, blood flow is blocked to very small arterial vessels. These are called lacunar infarcts and are most likely caused by hypertension. The two types of hemorrhagic stroke include intracerebral, which is bleeding into the surrounding tissue from a vessel. It's primarily caused by hypertension. It's also caused by AVMs, or arteriovenous malformations. Then the other type is subarachnoid, which most often is caused by a burst aneurysm. It's a stroke that occurs when there's bleeding into the subarachnoid spaces and the CSF spaces. Other causes of subarachnoid hemorrhage include AVM, bleeding disorders, head injury, and blood thinners. This slide, image A in this slide is a large left parenchymal hematoma, which is causing a midline shift to the right. The blood is white, a big round white area you see there on the left. It's inside the brain parenchyma. Now this would be an intracerebral hemorrhage because it is within the brain tissue. It's not out here on the edge. It's not inside the sulcus. The falciform ligament. I think that's what that's called. And then the image on the right, B, represents a subarachnoid hemorrhage, which is outlining the cisterns of the skull bases. And you can see here how the white areas, the blood, of course, outlines the path that the circle of Willis follows. It's filling in all these cisterns, or these cavities where the CSF flows in the brain. So that's a subarachnoid hemorrhage. We will look at these in more detail. We'll see some more images of stroke and bleeds in the pathology course. I just wanted to bring this up now while we're talking about CT perfusion studies so that you can understand what we're kind of looking for. And a lot of these two images are a little bit severe for stroke, but the ischemic strokes are the main ones that the CPT is used for anyway. So we'll catch up next week, or next lecture, with a CTA of the neck is what we're going to look at next week.